So today, I would like to focus on a few important points, and let me see. I would be talking to you about this topic for another 45 minutes to 1 hour, and at the end, I'd be more than happy to take few questions also. Okay. So why do we need sedation and analgesia? So did we ever realize, whenever the patient is in the hospital, they are in anxious state, and they have some or the other comorbidity or the disease problems, and patient, in the hospital is worried about the disease and the fate. They are not aware of the fate of their outcomes, as well as to whether they will survive, or whether they will have one or the other complication. So nearly, majority of the patients in the ICU require some kind of this soothing. It can be either in the form of pharmacological interventions, or this can be non-pharmacological also. And worldwide, the studies have shown that, if you control anxiety and analgesia, probably majority of the disease can be controlled with at ease. And it has been seen that 50% of the times the anxiety and analgesia does the job, and the disease entity will be controlled with the different medications. And if you don't control anxiety, don't control pain, it leads to systemic inflammatory response. And that systemic inflammatory response can again lead to, hyperimmune response. And then there will be exaggerated inflammatory response to the disease. And then patients not only deteriorate due to these hyperinflammatory response, but they stay in the hospital for longer duration. Their cost of treatment associated with the disease is also extended. And overall, the expenditure associated with the treatment is also very high. So that's why it has been found that this anxiety and pain has been the major factor for patients' recovery. And delayed recovery is very common, but now we have scientific ways to control the anxiety, whether it is pharmacological or non-pharmacological. As we are aware that a lot of technological tools have come up, and with these technological innovations, we have seen that these medications can be titrated. As we know that with the pain, patients have tachycardia, and whenever the patient has tachycardia, their diastolic time is reduced, and we have seen that due to tachycardia, the myocardial oxygen consumption is also increased. And whenever as we see that the myocardial oxygen delivery is maintained during the diastolic phase of the heart. And if the diastolic phase is reduced, so the oxygen supply to the heart is compromised. And this is especially important in patients with myocardial disease or myocardial infarction or ischemic heart disease, where if the pain is not controlled, the tachycardia can worsen ischemic condition of the heart. And that's why it is very much prudent and very much important that we should control tachycardia, which is the end result of any painful stimulus. And the painful stimulus will lead to a stressful response, which can also lead to increased catabolic state, and there will be release of hormones, and there will be release of inflammatory mediators, which can also lead to hypercoagulable state. And when the patient the patient has deprivation of the sleep and pain, the circadian rhythm is also disturbed. Okay, so majority of the times you will see the patient is sleeping in the daytime and he's remaining awake in the night. And as a result of which, due to the disturbed circadian rhythm, so sedatives after sedatives, and then the patients will remain addicted also to, especially to the opioids. And as you see that if there is over usage of these medications, there is tachyphylaxis, and then these drugs may not be useful. So later on, patient may require one or two or three drugs for control of pain and probably anxiety also. And it has been seen that these patients, the agitation is supposed to be, seen in patients with the medical and surgical ICU patients, especially when the patient has undergone surgery, they have pain, they have anxiety, they may have hypoxemia, they may have hypercarbia. The CO2 retention is also one more factor which can cause agitation, irritability. And the sleep deprivation is seen in 50% of the patients. Okay, so that's why we should follow a concept of analogous sedation. If you just treat with sedative agents, patient will still not be happy with the regimes that you will be providing. Their analgesia is not taken care of, still they will be agitated, irritable. If you are given good analgesics, but the sedative agent is not given to relieve anxiety, these patients will remain still agitated, irritable, or they will have delirium or something like that. So that's why. So it is very essential that we should take care of both sedation and analgesia as a holistic approach for control of the patient's disease condition, where as far as the pain and the sedation is concerned. And we need to also treat and identify the problem for which the patient is complaining of pain and why the patient is delirious. Okay, we also need to understand the physiological abnormalities that are associated with the pain and inadequate sedation. And then we should also be able to pinpoint as to how much should be the duration of the pain medications. Sometimes the patients have been given inadequate pain supplementation, so their pain cycle is not broken. So they will have a residual pain, and then that pain will again keep on aggravating. So we need to define the duration of these analgesics, and also we should choose the appropriate drugs. Okay, whether opioid or whether NSAID, it has to be chosen appropriately. And now we have a concept of multimodal analgesia. As we know that pain receptors are, different pain receptors are there, A delta, C fibers, and there are prostaglandin inflammatory, mediators also released. So we need to assign the analgesics which will target these different receptors. Okay, suppose we have injury to the hand, okay, or the limb. So initially, whenever we have the injury to the limb, there will be release of inflammatory material, the prostaglandins will be released. That will stimulate A delta C fibers. These A delta C fibers will carry the impulses to the mu receptors located on the dorsal part of the spinal cord. And from these mu receptors, the stimulus the impulses will travel along the spinothalamic tract to the thalamus. And in the thalamic region, it will also relay in the cerebral cortex. With the thalamo-cerebral reticular activating system will be activated, and it will be analyzed in the brain, cerebral cortex, as to what is the intensity of the pain, what is the type of the pain, whether we should withdraw to that painful stimulus, or so the reaction depends upon the intensity and the pain score and the quality of pain. And then cerebral cortex and the reticular activating system will again send the response to the thalamus, and from thalamus to spinothalamic, thalamospinal tract, and then to the effector organ. Okay, so unless we take care of these different receptors, whether it is A delta C fibers or new receptors on the spinal cord, so that's why it is very essential that we follow a multimodal approach where we have to use these agents together to control and correct the pain cycle. Okay, so I think you have understood the different receptors. The peripheral receptors are A delta C fibers. In the spinal cord, mu receptors are located, and in the thalamus and the cerebral cortex, we have GABA receptors. So when we want to have a complete control of the pain, we need to block A delta C fibers, we need to block mu receptors, and we also need to block GABA receptors. Then only probably we will be able to take care of the pain cycle. And naturally, the GABA receptor will be very well taken care of by the benzodiazepine receptor blockers. Okay, midazolam or lorazepam or different, sedative agents. And then A delta C fiber is very well taken care of by the NSAIDs, and mu receptors are better controlled with the help of mu receptor blockers like opioids. Okay, so that's why it is essential that which receptor is important for you to control pain, and we should use these agents judiciously. So apart from these pharmacological means, then non-pharmacological therapy is also very important. Good counseling, a good interaction, a good communication with the patient, having an eye-to-eye contact with the patient, considering his pain problem as significant one, and giving empathy, and trying to win the confidence of the patient, and try to make sure that we will help the patient with every possible ways to control the pain. The patient will definitely be relieved, and then pharmacological therapy, pharmacological support can be a definitive one. But the ancillary treatment can be in the form of non-pharmacological counseling based therapies is very important. That's why communication, time to time communication with the patient and the families is also very important. And then as far as the pharmacological therapies are concerned, we have different drugs like analgesics, sedatives, and neuroleptic agents. And this is how we should use different agents as far as the analgesia is concerned. Okay, so when we consider somebody has having pain, so we need to find out the severity of the pain, whether the patient has mild pain or moderate pain or severe pain. So these three factors are very important. Unless we defined the severity of pain, we won't be able to choose an appropriate agent for that particular patient. For example, if the patient has mild pain, you probably need just paracetamol. And if the patient has moderate pain, so probably this patient will need weak opioids like codeine or tramadol. And if the patient has severe pain, patients will need strong opioids like morphine and fentanyl. Okay, so or if the and then in case where the patient has severe pain, we can also use adjuvants together along with the opioids like NSAIDs or amitriptyline, or probably steroids can also be used. So for that, we need to specify how is the severity of the pain. So how will you define? So we need to have visual analog score or a pain score. Okay, so suppose you give an example to the patient. So if 10 is the highest pain score and 0 is the least kind of pain score, 0 to 1 is probably the least pain score. So patient should be able to tell you the severity of pain in terms of these numbers. But look at the patient also, you can assign if the patient is wincing, okay, he's showing some different gestures which are mimicking the painful responses. So probably the patient has severe pain. But if the patient is, patient has pain only after some stimulus or something like that, okay, after painful stimulus, but at rest probably the pain is less, but it gets aggravated by some factor, then probably we call it as moderate pain. Mild pain is something like when you give, severe pain or which is aggravated by forceful or vigorous work, then we call it as mild pain. So that's why categorization of the pain score is very important. And the pain is considered as the sixth vital parameter. So first vital parameter is pulse, blood pressure, respiratory rate, and saturation, oxygen levels with saturation, and the pain is also considered as the important sixth vital parameter. And then we should have a stepwise step ladder pattern for control of pain. Pain will target data fibers is good enough. Okay. And so probably the NSAIDs can also be used in this situation, where the NSAIDs will also target A delta C fibers and will be good enough for control of mild pain. But if the patient has a moderate pain, okay, so if the moderate pain is something where the pain score is between 3 to 5, okay, and mild pain is 0 to 3 is mild pain, 3 to 5 is moderate, and beyond 5 to 10 is called as severe pain. Okay, so if the patient has moderate pain, weak opioids like tramadol should be sufficient. Okay, and then as for strong pain, for severe pain, the strong analgesics like morphine, fentanyl, which is 100 times superior to morphine, can be used, and basically the action of these opioids is on mu receptors. But probably only opioids may not be sufficient in patients with this to adopt multimodal analgesia. You may have to add NSAIDs, you may have to add amitriptyline, tryptyline, and some anti-inflammatory agent like corticosteroids can also be used. But these are all adjuvant therapies in addition to the opioid receptors. So how do we use these different agents, opioid agents? So morphine being popular a few decades ago, but now it has been superseded by fentanyl because morphine has been abused quite a lot, and then it has been found that it has some residual sedative effect, and patients with the renal failure will have prolonged effect of morphine, and it also causes itching because it causes histamine release. Though the half-life of morphine is 3 to 7 hours, okay, but it has prolonged action, and it's one of the strongest opioid analgesic agent. And the dose regime can be 0.01 to 0.15 milligram per kg IV in intermittent dosages, and for infusion, the dosage range is between 0.07 to 0.5 milligram per hour. And codeine, the half-life of codeine is 3 hours. It gets metabolized by demethylation and glucuronidation. It's also one of the analgesic agent which is effective for moderate pain, but it doesn't cause any histamine release, so itching is absent, and it has to be given only in uh, uh, very limited situations, because linked codeine is basically given in the form of syrups and all that, so intermittent dosages and infusions are not recommended. So fentanyl is pretty strongest analgesic agent, but half-life is short compared to morphine. The half-life is 1.5 to 6 hours, metabolized by oxidation, and it has no metabolite, and it doesn't get metabolized in any other active form, so it itself is an active form. But in high doses, the rigidity or chest wall rigidity is seen with fentanyl, and it can be used in intermittent and continuous infusion. Continuous infusion is better, but for short-term pain relief, so intermittent dosages of fentanyl is also good enough. 0.35 to 1.5 mics per kg per hour infusion is quite sufficient. So pethidine, the half-life is 3 to 4 hours, metabolized by demethylation and hydroxylation. It also has neuroexcitability, and it has to be adjusted in patients with the renal insufficiency, and it should not be used with MAO inhibitors and SSRIs because it may have the cumulative effect, and it is not recommended now. Remifentanil, it is not available in majority of the centers, where metabolized by esterases, but it has a longer half-life, 3 to 10 hours, and infusion can also be used. So, but the problem with the morphine is that before it gets metabolized to an active form, it has to go through different stages. The morphine gets converted into morphine 3 glucuronide, 6 glucuronide, and it gets accumulated in the kidneys. Patient with the kidney failure, you will have to use it judiciously, and it can cause hypotension due to histamine release because it causes and and it doesn't cause instability that is useful in patients with instability. So, so pethidine is metabolized into norpethidine, but it has neuroexcitability problems. Codeine lacks, potency. That's why it is not recommended nowadays. But this, some of the commonest side effects of these opioid analgesics is respiratory depression. It can cause hypotension, and patient will remain drowsy, and it can cause constipation. So majority opioid are notorious to cause, ileus-like picture, and bowel motility may recover within 24 hours.